Very good evening to one and all, and warm welcome. We have gathered here for an engaging and insightful academic session that is to follow. Indians are known to have high coronary artery disease rates, and they tend to have multiple cardiometabolic risk factors. In fact, CVD accounts for 32% of all deaths in India. ESC in 2019 introduced the term chronic coronary syndrome (CCS) to encompass a range of clinical presentations and disease entities, including INOCA and ANOCA. To discuss about the latest methods, evidences, and recommendations on CCS, we have eminent faculty with us, and I have the honor of introducing them. For the first talk on optimizing anti-anginal management for CCS in Indian clinical setting, we have Dr. Jamshed Dalal sir with us as an esteemed speaker. Sir is Director of Cardiac Sciences at Dhirubhai Ambani Hospital and Medical Research Center in Mumbai, has 40 years of clinical experience in cardiology, has extensively worked on angiography and angioplasty procedures, has numerous publications in both national and international reputed journals. Also, Sir has been course director and esteemed speaker at numerous cardiology conferences over the past 30 years. We welcome Dr. Dalal sir. For the second talk on role of nicorandil in patients undergoing PCI, we have Dr. Sameer Kuba sir as an esteemed speaker. Sir is Director and Unit Head of Clinical and Interventional Cardiology at Mohan Heart Care Clinic in Delhi. Sir has played instrumental role in initiating primary angioplasty program in various hospitals in Delhi and NCR. Sir has been invited as esteemed faculty and speaker at various national and international cardiology conferences and has also been part of expert panel of LAI for formulating consensus statement for dyslipidemia management in Indian patients. Also, Sir has numerous publications in national and international journals. With this, we welcome you, sir. And I now hand over to our first speaker, Dr. Jamshed Dalal, sir, for his talk.
Thank you very much, Chami. Let me share my slides and we can start. Can you see my slides? Can you hear me, please?
Yes, sir.
Okay. So, hello, friends. We're going to have a session today about chronic coronary syndrome and also about the importance of nicorandil, both in management of chronic coronary syndromes and in PCI. As you know, this ESC 2024, which just completed in London, had a full guideline article paper on management of chronic coronary syndromes. And I think it's important to understand the importance because I think from the point of coronary artery disease, chronic coronary syndromes are the most important. As you know, what we used to call in the past as stable angina, that is now called as chronic coronary syndrome because we know that stable angina can become unstable pretty soon. And similarly, you can get a non-ST-MI elevated MI or a ST elevated MI. So today we are not going to talk coronary syndrome, restrict ourselves to what used to be called as stable angina and now called as chronic coronary syndromes. As already mentioned, there's a huge population of in India which presents with angina. Many of them have coronary artery disease. About 75 million have angina. And then, of course, they're poorly controlled, most of them in spite of therapy. And then large number of them also have microvascular angina. Many of them, of course, proceed to ACS and further problems. Now, if we look at ischemic heart disease and the term chronic coronary syndromes, I think that they manifest in different ways. Of course, all of them have myocardial ischemia. Some of them have got fixed narrowing in the coronary arteries, the major coronary arteries. Others have metabolic dysfunction. Others have vasomotor problems, coronary vasospasm, endothelial dysfunction, very important microvascular dysfunction. A lot of talk recently also about inflammation and atherosclerosis. So you can have stable angina pectoris, you can have a vasospastic angina and a microvascular angina. And so it's important to understand this. Because stable angina doesn't mean patients all need angioplasty or bypass surgery. There'll be a significant group of patients who require only medical treatment and a significant number of patients who remain symptomatic in spite of intervention. So patients with chronic coronary syndromes may present in many ways, often as the commonest, of course, being stress-induced angina, equivalent of obstructive coronary artery disease. Then, of course, patients who had an ACI, who bypass and or angioplasty, and who still have various plaques and now stabilized, but still having a lot of plaques. Then, of course, those some may manifest with LV dysfunction and heart failure. And then others would be totally asymptomatic in spite of severe coronary artery disease and can only be picked up on functional testing. And then, of course, you have this large group of patients who have got angina or angina-like symptoms, but with no obstructive coronary artery disease. And I think we need to look at each of these in its own importance. So if you try and assess them, you have patients who present with angina. Of course, if they have ACS, no question. They go to the cath lab, they have procedures done. So we are always, please remember, when you talk of medical therapy, wait and watch, etc., we completely exclude ACS. ACS needs to be treated by urgent, immediate intervention. We're talking of the second group, which is the one which is not presented as ACS, the suspected of chronic coronary syndromes. Of course, we need to look at the pre-test likelihood of coronary artery disease, which is very important. A 65-year-old man with diabetes, hypertension, and family history of coronary artery disease is much more likely to have coronary artery disease compared to a 30-year-old woman who has no such risk factors, even though both may present to us with chest pain. So I think pre-test likelihood is very important. Then, of course, we need to look at various laboratory tests, ECG, echo, and coronary artery calcium score, which has also become an important part of evaluation of the risk. Of course, all this, if it points to low likelihood of coronary syndromes, then you don't do anything too much. You just follow them medically and decide what to do further. If they fall in the intermediate group or highly likely group, then of course you go into more invasive testing, maybe a coronary CT scan or even an invasive angiography. And of course, if they're intermediate. So you clearly use your clinical judgment, history, blood test, ECG, echocardiography, and then decide about whether the patient needs a CT coronary angio or a stress test or a direct angiography, depending on your assessment of the likelihood of coronary artery disease. One important factor that we should know is that even patients with non-obstructive coronary artery disease have a cardiovascular risk. So please do not feel that if you have a patient who has typical angina, positive stress test, you do an angio and it's normal. You don't just pat the patient on the back and say, oh, there's nothing, it's all in your mind. You really don't have any problems. That's not true at all. The rate of CV death, the rate of major cardiovascular events, and even the rate of all-cause death is high even in those with non-obstructive CAD. So it's not as high as in patients with obstructive CAD, and of course not as normal as those with no problems at all. But non-obstructive problems can also be associated with cardiac events. Now, this was the sort of guideline presented in the previous ESC meeting, 2019, that the most important thing about angina patients' treatment, and I'll talk about how we should not rush to angioplasty and bypass surgery in patients with stable or chronic coronary syndromes, because clearly what you really need to do is treat the angina. And as I'll show you in the later slides, beyond that, very little is being done by intervention. So first and most important, of course, you want angina relief. And they suggested, of course, the use of beta blockers, calcium channel blocking drugs, or combination of the two as clearly as the first line of drugs. And of course, nitrates as and when required. And then, of course, they said the second line of treatment, that means the second line, ivabradine, long-acting nitrates, nicorandil, ranolazine, trimetazidine. But this is just a thought process which has been going on for years. There's no evidence to suggest that this should be the first line and this should be the second line. I could well challenge it and say, let's start with these drugs first, the second line, and then give the first line drugs only if the angina doesn't subside. But clearly, I think today, let us be honest, in practice, most of us would start beta blockers unless they're contraindicated. If beta blockers are contraindicated because of acute asthma or any such issues, then of course verapamil, diltiazem group of drugs, the calcium channel blockers, which will also produce bradycardia, and of course nitrates. And of course, second line, then of course, if this doesn't work or if it's not tolerated, then you have multiple other drugs, which I think of the lot, ivabradine, ranolazine, nicorandil, and trimetazidine as more important. If the angina cannot be controlled, or the CT angio or other procedures show that there is a high probability of future events like a severe left main lesion or a severe triple vessel disease with poor left ventricular function, then of course you need to proceed to further treatments like angioplasty or bypass surgery. I mentioned the treatment of angina, but that's one part of it. That's the relief of angina. But you need to go beyond that. You need to prevent them from getting into an infarction. And you mustn't forget about antithrombotic treatment. I won't go into too much details, but in a chronic situation, the chronic coronary syndrome who's not undergone a procedure, we don't usually use prasugrel or ticagrelor. Most of us will use aspirin and clopidogrel or one or the other. A lot of data today seems to suggest that if you're going to use a single antiplatelet drug over a long period of time, that clopidogrel may in fact be better because it produces good beneficial effects on ischemia and produces less bleeding compared to aspirin. And of course, if you have patients with polyvascular problems, that means coronary artery disease with peripheral artery disease or with stroke, and then you of course have to think of a dual pathway, that is a small dose of rivaroxaban, the vascular dose 2.5 milligrams twice a day, along with aspirin. Some people have also used rivaroxaban vascular dose with clopidogrel, but the COMPASS study was only this aspirin plus rivaroxaban. So we do not have any data on vascular dose of rivaroxaban with clopidogrel. NOACs generally are not combined with ticagrelor or prasugrel because of increased incidence of bleeding. Most important in treatment of chronic coronary syndromes is lipid-lowering drugs. And if you can see from here, the ESC recent guidelines, class 1A indication, lower the LDL to below 55 milligrams and a more than 50% reduction of LDL. And of course, if you look at the Lipid Association of India guidelines, we have been even more strict in the guidelines, where we brought the values down to below 45, and in those patients who are extreme high risk, even below 35. So I think clearly it's very important to bring LDL down, either through the use of statins, high dose, moderate dose, along with ezetimibe, which I think, but personally, I think the combination of statin plus ezetimibe is extremely beneficial. And I think that this should be combined for all patients, according to me, not simply start on statins and then later consider ezetimibe. Of course, if the patient does not tolerate or does not want statins because of all the negative publicity of statins, we fortunately have bempedoic acid. And if this doesn't control the levels, then of course we got PCSK9 inhibitors, and we got both evolocumab and inclisiran both available with us for use. So clearly, any of these can be done. There are a number of trials, including a pilot study by the Lipid Association of India and other studies, where they've in fact combined bempedoic acid, ezetimibe, and statin, all three together, in patients with ACS. And they find that combining all the three together, it's a very rapid and a very significant, more than 50-55% reduction in LDL, almost like a PCSK9 inhibitor. So clearly there are multiple options today with us. We just can't say, oh, patient doesn't tolerate statin and not do anything. You got statins, ezetimibe, bempedoic acid, all three combined together, evolocumab once every month or 15 days, and of course inclisiran once every 6 months. So we really have no reason to believe that we should not or cannot control LDL. And again, as I mentioned, in patients with chronic coronary syndromes, bring the LDL to below 55 milligrams at least. There are other more interesting data coming out. As you know, SGLT2 inhibitors and GLP-1 receptor agonists have been proven to be beneficial for these patients. We know for a long time when the first GLP-1 receptor agonist came that they had benefits in terms of cardiovascular prevention. And of course, SGLT2 inhibitors more in terms of heart failure and kidney benefit. So clearly patients with coronary artery disease will benefit from SGLT2 inhibitors and GLP-1 agonists. Of course, recently, the use of GLP-1 agonist in obesity with the tremendous problems related to obesity, diabetes, hypertension, and associated coronary artery disease, these drugs become extremely important. So do not forget the role. And if you can see out here, the 2024 recommendation, SGLT2 inhibitors in type 2 diabetes and coronary syndromes reduce cardiovascular events. We know that. We even know that SGLT2 inhibitors can reduce cardiovascular events even in patients who do not have type 2 diabetes, but clearly the presence of type 2 diabetes makes it mandatory, 1A classification. GLP-1 agonist proven CV benefit. Again, don't forget that. Again, data suggesting that these can benefit patients even in the absence of diabetes. So clearly, I think remember these drugs as well. So number one, anti-anginal therapy, as I mentioned to you, so many drugs. Number two, antithrombotic measures. Number three, lipid measurement. And number four, GLP-1 agonist and SGLT2 inhibitors. And of course, there's a lot of talk about anti-inflammatory drugs. We know there are a number of trials looking at low-dose colchicine, 0.5 milligrams in acute ACS. And clearly in an acute ACS, it should be used. But again, the use in chronic coronary syndromes is class 2A because there are not too many studies done on colchicine in chronic coronary syndromes. But if you have a patient who's had repeated procedures, even though he may not have had plasty or anything done, but many people have chronic coronary syndrome, multiple blockages, or post-angioplasty, post-bypass. In such a situation, especially when the hsCRP is high, I think use of colchicine, in addition to the statins and all the things I measured, would be considerably beneficial for these patients. Again, I must mention that we should not think simply that a patient has angina needs to be revascularized. I think that's been now going on for a long time. And let me take you through some of the studies. Now, we know that many studies have shown, starting with the Courage to earlier, Barry, Fame, that angina often persists even after you do angioplasty. So clearly, angioplasty is not the solution. In fact, 1 out of 3 patients after PCI can have angina all over again as early as 1 month, and even more patients over 12 months' time. So clearly, we have to think of things. Again, you must remember that patients who remain with angina, the CLARIFY trial was done with a large number of patients presented at ESC in 2020. It showed that when patients had angina, the chances of cardiovascular death and MI was significantly higher. So the presence of angina post-procedure is associated with increased mortality and morbidity. So I think any angina post-procedure has to be looked at very carefully. I mean, I'll talk a lot about chronic angina and the role of microvascular angina. You can see the endothelial being damaged with microvascular angina. And again, this is a nice picture. I'm not sure you can see the details. This is an algorithm in the 2024, just recently presented at ESC in evaluating patients with ischemia with non-obstructive coronary arteries. So you do all the studies, you do the angios, etc. You find that there are no problems, yet the patient has maybe positive stress test or a PET scan which shows positive. There is some problems related to SPECT test, thallium which shows positive. So there is definite evidence of angina. There's definite evidence of ischemia shown on the objective test, and yet the coronary arteries are not normal, in which case you can do what is called as invasive coronary functional testing. So you can do testing using adenosine, acetylcholine small doses, acetylcholine high doses, and look at for abnormal vasoconstriction which acetylcholine can produce, and abnormal vasodilatation as can be seen in adenosine. So you can do various flow studies in the coronary arteries along with drugs. And if I can go one more slide, which ESC has presented, and this is acetylcholine adenosine-based vasoreactive protocol. So when you're doing these tests in the cath lab, you must stop beta blockers, nitrates, and calcium channel blockers because you don't want the vasodilatation to affect by these drugs. So you do a basal angiogram, and you're doing all your monitoring. So then continuous Doppler monitoring, ECG, etc. You give low dose acetylcholine, high dose acetylcholine, more high dose acetylcholine, then you give nitroglycerin, then you give adenosine. So we used to do also long time back when we were studying these patients, we used to give drugs in the cath lab to induce vasospasm, and it was dramatic. Some of these patients would go to severe vasospasm, have severe angina, the STs would shoot up, and we had to push in intracoronary nitroglycerin to stabilize these patients. We even tried other things in the cath lab, seeing like whether smoking or exercise using a bicycle while doing cath procedures can precipitate vasospasm or ischemia. So there's a lot that we can do simply rather than just looking at the big coronary arteries. So of course, the treatment of these patients is a more generalized treatment. So when you treat these patients, you have to look a lot at their lifestyle. So you need to improve the nutrition, exercise, stop smoking, alcohol, weight management, control the hypertension, dyslipidemia, diabetes. Of course, this is all important even if you have a blockage, but even more important if you don't have a blockage. And if you look at medical treatment, then you have to look at two aspects of it. If there's abnormal vasodilatation or abnormal vasoconstriction. If there's abnormal vasoconstriction, you want to give large amount of vasodilators like calcium channel blocking drugs, nitrates, nicorandil. If it's more microvascular, then beta blockers, ranolazine, which has some beneficial effect, and of course trimetazidine, which has a very marked beneficial effect in microvascular. So clearly the drug therapy will depend on whether you're getting vasoconstriction, vasospastic angina, microvascular angina. Because it's not very easy to make these diagnoses clinically. So you have to rely on some of the tests, and even then it may be difficult. Now, nicorandil is a drug which we are trying to talk a little bit more about today. So nicorandil is a very good drug. It prevents where prevents causes ischemic preconditioning, therefore reduces angina and ischemia, and it's also a very good vasodilator. We use it a lot even in cath labs. We give it before procedures. In patients who come with an acute MI, we give it intracoronary as well. Many patients who have no flow after angioplasty, we give intracoronary nicorandil with great benefit. So nicorandil has nitrate-like action. That means it dilates the large epicardial arteries. It also produces venodilatation, and it also acts on potassium channels and produces the dilatation of the peripheral arteries. Therefore, it will reduce myocardial oxygen requirement because of decreasing preload because of venodilatation and peripheral artery dilatation. It also dilates the coronary microvasculature. It also increases coronary flow. So beneficial in terms of ischemic preconditioning, beneficial in terms of microvascular problems. So compared to beta blockers, of course, if you have patient on beta blockers and you give them nicorandil, their exercise time will improve, the time to angina will improve, the 1 millimeter ST depression compared to calcium channel blockers, again, benefits. So this drug benefits people even in the presence of beta blockers, calcium channel blockers. Of course, many of the effects of nitrates and nicorandils may be same, but the effect on the microcirculation is much more with nicorandil as compared to a nitrate. Now, I also talk a lot about metabolic modulator because I also feel, especially when you're talking of ischemia in patients with normal coronary arteries, must remember that ischemia occurs at the cellular level. Ischemia doesn't occur at the left main coronary artery. It in fact doesn't even happen at the microcirculation, actually happens at the cell. It's the cell which becomes ischemic. So therefore, you must look at the cellular metabolism and the conversion of fatty acids to glucose. There's too much fatty acid production, then you need drugs to convert the fatty acid to glucose production. The advantage being that that will promote more ATP generation for this amount of oxygen. So if you've got a fixed amount of oxygen, it's getting gradually less because of ischemia. Then if you convert to free fatty acid to glucose metabolism, more oxygenation will be available, more ATP will be available for the same degree of oxygen, and therefore ischemia will be reduced. The number of drugs available, some of you who are old will remember Perexaline, which was available like 40 years ago, not available now. Then, of course, carnitine, coenzyme Q10, they have beneficial effects. Even beta blockers have some effect on free fatty acids. Of course, the most important drugs as far as metabolic modulation is concerned, in my opinion, the most important is trimetazidine. Ranolazine has dual action. Part of it is through the metabolic pathway as well. So ranolazine improves heart function and ejection fraction both, and of course angina. It reduces the late sodium current, reducing myocardial calcium overload, alters the parasympathetic sympathetic activity, and also partly affects the free fatty acids, therefore favoring the glucose pathway. Trimetazine, of course, is a much specific drug as far as the ischemia is concerned. Now, trimetazine, some of the earlier studies which were done like about 20 years ago, and very recently the modus vivendi study, which again looked at the use of trimetazidine in addition. So these are people on beta blockers. When they were given trimetazidine, there is a significant reduction in the number of anginal attacks. If they were on beta blockers and calcium channel blockers, they still had reduction. If they were on beta blockers, long-acting nitrates, or even all three, they still got benefit. So the advantage is that you can use a drug like beta blocker or calcium channel blocker or so many other drugs, which basically what we call as hemodynamic drugs. But at the same time, the addition of a metabolic drug like ranolazine or trimetazidine can have benefits in addition. So this is not too much discussed by ESC for the simple reason that trimetazidine does not have any single large study. No single large randomized study with trimetazidine has been done. So therefore, obviously, guidelines cannot put any of these into top line, though they have mentioned about it, and I'll show it to you a little later. Trimetazidine also is very beneficial when given at the time or before PCI, especially in a situation of acute coronary syndromes, acute myocardial infarction. If you give the patient trimetazidine, something like 2 tablets of trimetazidine MR just before the procedure, then that will produce benefits in terms of prevention of reperfusion injury. Whenever you reperfuse an artery which is totally blocked, which is exactly what you do with an acute myocardial infarction angioplasty, then you get reperfusion injury. You can prevent this reperfusion injury with the use of these drugs. And this can benefit in these patients. There are a number of studies, I can show you many of them, reduces rate of hospitalization, rate of revascularization. So please also think of metabolic drugs, think of other drugs besides just thinking of beta blockers itself. So I think the concept of treatment of myocardial ischemia, coronary syndromes would be hemodynamic agents, which I mentioned to you, all the beta blockers, calcium channel blockers, nitrates, etc. Also think of metabolic modulators like ranolazine and trimetazidine. Also think of nicorandil, which has both hemodynamic and other benefits. So I think a combination of therapy is probably the best way to treat the patient. Now, many patients cannot tolerate beta blockers or not enough severe heart rate reduction. So clearly the addition of ivabradine, ivabradine is another very important drug. So you combine ivabradine along with beta blockers to get a further benefit in terms, because your aim in chronic coronary syndromes is to reduce or stop the angina. Because if you can stop or prevent angina, then this patient doesn't need angioplasty or bypass unless the location of the lesion, as I mentioned, left main or a trifurcation lesion in the left main LED circumflex. If it's not there, then this people can be managed as long as you can control the angina. So there are many ways in which you can control angina. Now, again, as I mentioned earlier, I don't want to go into this whole topic, but PCI has no impact on prognosis. So PCI in all these studies have shown that's very good in terms of relief of angina, but not so much good in terms of it doesn't prolong life of any patient who undergoes PCI, unless for a very specific group. And again, please remember, I'm talking of chronic coronary syndromes. I'm not talking of ACS. In ACS, PCI is life-saving. There is no question about that. Another trial, more recent, called the ischemia trial, again showed that whether you did an invasive group or medical group, really there's no significant difference in terms of cardiovascular death, MI, or all-cause death. And then, of course, the Orbiter trial, which is actually a very interesting trial where randomized placebo-controlled trial of CTO along with a sham. So this was done in UK with a sham. So one patient actually had a sham procedure, means they actually did everything except do the angioplasty, and the other one had an angioplasty done. And the interpretation was that patients medically treated with angina and severe coronary artery disease, PCI did not increase exercise time by more than the effect of placebo procedure. The efficacy of invasive procedures can be assessed with the placebo control as a standard. So clearly there was no significant benefit in terms of these. Then Orbiter went ahead, the same group of people in UK went ahead and did the Orbiter 2 trial, which was again a placebo control according and associated with the sham. And here what they did is in one group they gave no medical treatment, and the other one they did angioplasty. And they found that yes, angioplasty, the conclusion was that angioplasty in stable patients, that is the chronic coronary syndromes, receiving little or no anti-anginals with objective evidence of ischemia, PCI resulted in lower angina compared to sham. So to conclude, number one, PCI will reduce angina. So if you have two groups of patients, one was on no medicines and the other one who has no medicines and PCI, PCI will reduce angina. But if you give equal medicines to both the patients, PCI doesn't do anything dramatic in terms of prolonging life, etc. And this has been shown by the ischemia trial, the courage, all sorts of trials which I mentioned to you earlier as well. And therefore, it's important to remember that in chronic coronary syndromes, your first choice should not be a plasty, unless the patient has, as I mentioned, again, very critical lesion at a critical point in the coronary artery. That may be a little bit different. But even then, some of the studies like the Courage trial showed that even LAD proximal stenosis, there was really not much difference between medical treatment and procedures. ESC also mentions combination and best possible combination. So if you have a patient with angina and high heart rate, the obvious thing would be to use beta blockers along with verapamil or diltiazem or ivabradine. Personally, I would connect beta blockers and ivabradine. That's a very good combination. And you can co-administer ranolazine and trimetazine. So you got your hemodynamic drugs and you got your metabolic drugs, and that would be the best. If the patient has bradycardia and you can't use these drugs, and of course you have to use nicorandil, trimetazidine, ranolazine, nitrates. If the patient's got hypertension, then obviously beta blockers become very much more important. And then, of course, if you got hypotension, that's another problem. Very low blood pressure with angina, you can't use beta blockers, you can't use all these calcium channel blockers. Then again, the three drugs which do not affect the heart rate, no, ivabradine, of course, affects the heart rate. The drugs which do not affect the heart rate or BP, which is trimetazine and ranolazine, and ivabradine, which does not affect the blood pressure, can be used as an important therapy. If you got LV dysfunction and angina, then beta blockers are very important. Avoid using verapamil and diltiazem when patients have poor LV function. If the patient's got heart failure, then of course, again, beta blockers and ivabradine both have been proved to be very useful. The patient's got atrial fibrillation, again, diltiazem, verapamil, beta blockers. And of course, other drugs can always, trimetazidine, ranolazine, nitrates can always be used for any of these patients as an add-on to reduce angina. Couple of slides more. This is a very nice picture which was presented, was there in Nature Reviews in 2021. It's called the anti-anginal compass. So here you have your patient who's got angina. Then you look at the heart rate. Is the heart rate high or heart rate low? Then you look at the blood pressure. Is the blood pressure high or is the blood pressure low? And then you look at heart failure. Does the patient have heart failure with preserved ejection fraction, reduced ejection fraction, or nothing? So if, for example, you have a patient whose heart rate is high and he's got heart failure and he's got angina and his blood pressure is high, then you say, okay, beta blockers, ivabradine, long-acting nitrates would be the ideal drug. The patient, say, for example, whose heart rate is low and his blood pressure is low, he's also on heart failure and has angina, you can't use these drugs, ranolazine, trimetazidine, etc. would be the drug. So I think this is a very interesting compass. And in fact, the ESC 2024 has come out with even bigger and better picture. You can take your time and look at it. So you have this beta blocker therapy, then you have nitrates and nicorandil put together. Then you got ivabradine, you got ranolazine. They have trimetazidine as well. Though I mentioned trimetazidine doesn't have any large trials, nor does ranolazine, unfortunately, for that matter. Then you got the diltiazem verapamil. So clearly, if you got obstructive coronary artery disease, vasospastic, then you want vasodilators, which would be the most effective. So vasospastic angina, calcium channel blockers, and nicorandil would be beneficial. So vasospastic angina, nitrates, and nicorandil, most important. The contraindications, of course, if you have sick sinus syndrome, no beta blockers. If you got hypertrophic cardiomyopathy, no nitrates and no nicorandil. Sick sinus syndrome, no ivabradine. And if you got, again, diltiazem verapamil, then you don't use if you have sick sinus syndrome or if you've got heart failure with reduced ejection fraction. If you got obstructive CAD, microvascular dysfunction, trimetazidine or ranolazine. If you got vasospastic, nicorandil or nitrate. So I think it's a beautiful chart taken sort of partly from what I showed you in Nature a couple of years ago. But I think this really explains how you treat chronic coronary syndromes. But I think where does the problem lie? The problem lies in the fact that we, in spite of knowing everything, we simply don't treat our patients. That's where the problem lies. This is a study which shows before Courage trial, which showed medical treatment is so very important. And after Courage trial, which shows medical treatment is so very important, the medical treatment doesn't improve. So even though we may talk so much about medical treatment, we as cardiologists are more prone to put a stent and forget about it rather than take the effort, time to start patients on treatment. Someone might say, looking at the recent Orbiter 2 trial, that why bother with drugs when angioplasty can cure? So why take 5 drugs to reduce your angina if your angina can be reduced by medicine, by one stent? Well, there's definitely a possibility, and the persons you can discuss with the patient, but that does not mean that you don't need medical therapy. You have to put your stent, but you still need other medical therapy. So you may not need anti-anginal drugs, but control of statins, control of blood pressure, control of sugar, antithrombotic drugs, and of course, as you know, much more antiplatelet drugs with its own bleeding problems happen when you do angioplasty, use of colchicine for inflammation. So I think whatever you do. So I think I will end my talk by mentioning that it's very important that we look at chronic coronary syndromes as a whole group of
Probably Professor Jamshed Dalal has an internet connection challenge. He will join with us soon, but he has come. Yes, sir has joined us. Yeah.
Thank you so much, sir. Now we hand over the session to Dr. Sameer Kuba, sir, for his talk.
So can you hear me and see my slides?
Yes, sir.
Yeah, thank you so much. And Dr. Dalal, it's always a pleasure to hear you, and you cover almost everything in such a short span of time with crystal clear ideas, and it's always a learning from you, sir. Thank you so much. And I'll just speak on this molecule, nicorandil, and just delve into slight more details because everything has been covered so very well by Sir. So nicorandil is an excellent molecule, and we have been using it in chronic stable angina. We have been using it in acute coronary syndromes. We have been using it as an oral therapy. We have been using it as an IV therapy, as an intracoronary therapy. And I think it's a very, very safe drug, effective drug, doesn't cause much of hemodynamic issues. So it's a great drug overall in clinical practice. But let me delve into some of the data. We know that this is a molecule which is not only an anti-anginal, but also has certain other properties like anti-inflammatory, neuroprotective, nephroprotective, hepatoprotective, and obviously cardioprotective and testicular protective effects. And because this molecule not only affects the potassium channel and the nitrate pathway, it has effect on certain other protein ligands at the cellular level. So that is the reason that it has so many beneficial aspects. So not only an anti-anginal, it's an antioxidant, anti-inflammatory, also an analgesic. And as you can see on the right panel, that it affects positively almost all organs of the body. So this is the mechanism of action. I'll not go into the details. The only point we must understand here is that the mechanism of action is dual. So nitric oxide pathway and the potassium channel pathway. That is the reason you don't get much of headaches. You don't get much of rebound angina, and you have much better effects at the microvascular level as compared to nitrates. And in STEMI, not only does it dilate the coronary vessels, but it also reduces the vasomotor spasm, decreases noradrenaline release, and prevents lethal arrhythmias. And additionally, it limits the cardiomyocyte death by inhibiting the opening of the MPTP, which is the mitochondrial permeability transition pore. So the effect on the microvasculature, as Dr. Dalal was also mentioning, is excellent with this drug. And many times the angina is at the level of the microvasculature or even at the level of the cell rather than at the epicardial coronary arteries. And that is why we see many patients, despite open coronaries or mild disease, still complaining of angina, and we should not actually tell them that everything is okay and nothing is going to happen. So obviously they have higher risk than the general population. So this drug acts within 30 to 60 minutes. The effect lasts about 12 hours. The dosage usually is between 10 to 20 milligram daily. We also have a sustained release dosing, but we can go up to 30 milligram twice a day. It's recommended to start a lower dose in elderly patients, vulnerable patients, patients prone to headache. So at times you may start it as low as 5 milligram and gradually up titrate. This has already been covered. We know that there are various anti-anginals in the basket, and despite no class 1 indication as such for any drug, obviously we use beta blockers and calcium channel blockers first, and nitrates probably have the first comer advantage. But if you look at data, almost all drugs, as far as the anti-anginal efficacy is concerned, are equal. We have more data with mortality benefit with beta blockers and probably calcium channel blockers, but all these drugs can be used in various combinations. Now, the IONA study was a very important study which selected high-risk patients with stable angina who had higher risk of recurrent cardiovascular events and patients not adequately managed with conventional therapies. And what was found was that nicorandil had no evidence of tolerance with long-term use, which is probably more common with nitrates. And probably the reason for this is it has a dual mechanism of action. And again, there was no occurrence of rebound angina. So this is very, very important. And we see this in clinical practice. And it's a reliable option for ongoing management of stable angina. So I think it's a very good drug. Usually we do not combine nitrates and nicorandil together, but in certain situations we may need to, as I'll be discussing. Now, its role in percutaneous coronary intervention is also well known, although the trials are not multicentric, but there are individual trials, and we have also seen in our clinical practice, and we had a thesis also in our MD days, in DM days actually, on the role of IV and infusion of nicorandil prior to PCI. So this was a small study in Egypt on anterior STEMI patients where oral nicorandil was given, single dose 20 milligram versus a control group which did not receive nicorandil. And what they found was that over a period of time, the patients who received nicorandil had a higher ejection fraction and lower incidence of myocardial damage as assessed by the peri-procedural CPK and CPK-MB levels. So the conclusion was this was mainly anterior STEMI, that these single dose of oral nicorandil can reduce the myocardial damage and enhance the myocardial salvage, confirming its cardioprotective effect during PCI. And Dr. Dalal will also agree that we use it so very commonly in our PCI patients. Almost every patient of ACS, we are using it intravenous, intracoronary, and also as an infusion. Especially, it's a very good drug for coronary slow flow, prevention of no reflow phenomenon. And the beauty is does not cause much of hemodynamic compromise as is done by nitrates and also nitroprusside. Coming to vasospastic angina, this is one indication wherein nicorandil can be combined with nitrates for a favorable outcome. But usually when we use either of these drugs, we usually do not combine. Like we do not combine trimetazidine with ranolazine most of the time because the mechanism of action at the metabolic level, although dissimilar, but the pill burden may actually increase and not much of a benefit happens. But sometimes when the angina is unrelenting, you have to use a combination of these drugs. So this drug not only is well tolerated, but it improves the exercise tolerance, reduces the episodes of angina. And another advantage is you can reduce the doses of conventional anti-angina drugs. Like a patient may not be tolerating a high dose of beta blocker or a calcium channel blocker. So probably you can reduce the doses of those drugs and then add nicorandil so that you are able to use the multiple drugs without increasing the adverse effects of one drug. So overall quality of life is also improved to a great extent. Now, another advantage is reduction in stroke. So what was found when it was compared to nitrates is that nicorandil actually was associated with lower rate of stroke therapy when stroke incidence when compared to nitrates. And stroke is a common complication in CSD patients because of the combined and common risk factors, and also during intervention, periprocedural stroke can also happen. So nicorandil is a great drug in preventing stroke when compared to nitrate therapy. Again, the evidence is not multicentric, but yes, it is there. Now in syndrome X, as we were discussing, it is again an excellent drug, not causing much of hemodynamic compromise and improving the symptoms of chest pain to a great extent. The biggest advantage, it is very, very safe. The incidence of headache, etc., is also less because of the dual mechanism of action. Coming to microvascular obstruction, a great drug in preventing the slow flow, no reflow. And in fact, patients who are given nicorandil have a higher TIMI flow and also improvement in the distal velocities at the coronary microvasculature level. Now, this is the data which actually showed that when cardiac MRI was done in these patients, the microvascular obstruction was significantly reduced with nicorandil. And this is not only a conjecture, but it has been proven by the MRI. And we know many times when we do an intervention in a proximal LED, delayed presentation, you may open the epicardial vessel, but the damage to the microvasculature can lead to a lot of problems. And this drug can actually work at that level. This is again to show that the nicorandil group had a lower incidence of no reflow and slow flow and a reduced corrected TIMI frame count when compared to the placebo group. This is a trial which looked at the intravenous nicorandil 6 milligram. It was a trial of around 408 patients published as early as 2009. And when I was doing my DM in between 2005 to 2007, we also had a thesis of usage of intravenous nicorandil and an intravenous infusion of nicorandil for 24 hours post-procedure. And we found significant benefit in terms of resolution of the ST segment and CPK-MB rise peri-procedure. So this was a trial of 408 patients. 6 milligram of nicorandil was found effective for vasodilatation without causing significant side effects. Slow flow was reduced both in the ACS and non-ACS settings, and also lowered the rate of target vessel revascularization in ACS patients. Look at this mechanism. If you look at the fourth right figure with 6 milligram of nicorandil, the flow velocity signal measured distal to the stenotic lesion actually was significantly improved when nicorandil was used when compared to no nicorandil or a lower dose of nicorandil. So 6 milligram dose was used in this study. We usually use a lot of coronary nicorandil 2 to 4 milligrams, and then we give an infusion of about 0.5 to 2 milligram per hour infusion, which can go over a period of time for about 24 hours, especially in patients who are prone to no reflow, slow flow, or delayed presentation, wherein microvasculature is greatly affected. Now, intracoronary nicorandil also has a data, and intracoronary nicorandil has been studied very, very well. And as I was mentioning, the biggest advantage is that it does not cause much of hemodynamic compromise. So if your patient is having a borderline blood pressure, you will be afraid of using nitroprusside or nitrates also, especially large STEMI anterior wall. But with nicorandil, you are not much afraid because it does not cause much of hypotension. At the same time, improves the microvasculature. The crux is if you are able to give it a distal to the thrombus via the usage of a microcatheter or probably a balloon which is slit, probably the advantage is going to be much better. But many times we give it via the thrombosuction catheter also or directly into the coronary artery via the guiding catheter. Now, there's another data about 100 STEMI patients. 50 patients received 6 milligram of intracoronary nicorandil and 50 patients received placebo. So this is intracoronary of 6 milligram dosage. And what they found was that although on day one, the difference was not much between the nicorandil and the non-nicorandil groups, but at day 80, nicorandil reduced the BNP levels and LV end diastolic volume significantly when compared to the control group. So the effect does not happen immediately. It is translated into a long-term benefit. And I think the basic mechanism for this is the microvasculature, which is affected very, very favorably with this drug. And this is again to show that at the start, patients had a TIMI flow grade of 0, and nicorandil group showed significantly better outcomes with more patients achieving TIMI 3, both immediately after stenting at the end of the procedure when compared to the control group. Again, the ST segment resolution, TIMI grade 3, TIMI myocardial perfusion grade 3, resolution of the ST segment, and reduction in the ventricular arrhythmias was significantly better with nicorandil when compared to placebo. As I mentioned, better to administer this drug distal to the thrombus during PCI, but again, at times you may not be able to do that. If you're able to do that, the outcome probably is going to be much better when compared to a direct injection via the guiding catheter. We at times inject it through the thrombosuction catheter also when we are performing thrombosuction, or else we use a microcatheter, and probably if that is not available, we use a balloon which is slit, and that can actually be a good way to administer this drug in the distal microvasculature. And again, this is an advantage of this drug that it also affects the superoxide dismutase and reduces the antioxidant related the oxidant related injury and increases the antioxidant superoxide dismutase, and also eliminates or elevates the oxidative damage by limiting the rise in the malonyl dialdehyde levels as compared to control. So there is a molecular mechanism. I have not delved too much into the details because almost everything was covered to a great extent by Dr. Dalal. But let me tell you, this is an excellent drug, not only as an oral drug, but also an intravenous and an intracoronary drug, both for stable angina, unstable angina, acute coronary syndrome, ST elevation MI, cardiogenic shock even. We are not very afraid of using this drug because the hemodynamics are greatly favored. So thank you very much for your patient hearing, and then we can have discussion.
Thank you, sir, for your excellent presentation. So we have good number of audience questions. With your permission, I'll put forth few of them. So the first question is from Dr. Deepak, who asks about angina with normal coronaries. Angina with normal coronaries, what differential diagnosis should clinician consider? Dr. Dalal, sir, would you like to take it first?
Like a patient, first of all, you have to be sure that the patient has angina. I mean, you're not talking of non-specific pain or costochondritis, something like. Patient has typical angina. You do a stress test and it's positive, or you do a nuclear stress test and it's positive, or a stress echo and it's positive. So there's a clear evidence of clinical angina, that is symptomatic angina, and ischemia. And then the coronary arteries are normal. Then, of course, you have to think that this patient is not should not be dismissed as nothing to be done and not put on any treatment. This patient should be treated as a microvascular angina or a vasospastic angina. And I've shown you how some of the tests and studies can be done. However, even if you cannot do all these studies with acetylcholine, etc., or ergonovine provocation of coronary spasm, you can still treat them. So what you need to do is that instead of simply giving these people just beta blockers and nitrates, you must use drugs which are more specific for vasospasm, microvascular disease, etc. So as I mentioned, the 3 drugs which are predominantly useful in that category are ranolazine, trimetazidine, and nicorandil. So when you treat these patients with these drugs, then you'll find that they get symptomatic relief of angina and their ischemia improves and the stress time and ST segment depression improves. So treat these patients also have normal coronary arteries. In the past, we used to dismiss them and say, oh, there's no problem with you, there's nothing. But so clearly, even if you cannot prove it, treat them with these drugs. All the three drugs are pretty safe to use and give it a trial with these drugs.
Thank you so much, sir. Dr. Sameer Kuba, sir, your opinion on the same?
I think it's almost same. And one another additional aspect we must look at is anemia. And many times our patients have a low hemoglobin, and that could be a contributor to angina, thyrotoxicosis. All other aspects must be looked into. And I think anemia is very, very important, especially in females. And iron studies must also be done, especially if you have anemia. And these drugs are great drugs. You may have an evidence in the form of a positive TMT or the stress echo where you have STT changes. But I feel most important is knowing your patient. So if you know your patient well, if you can actually look at the history, you can do basic tests like an ECG or a TMT or a echo. Most of the times the diagnosis is clear, especially if the angiogram doesn't show any critical stenosis. Yes, provocative tests are important, but largely they are not possible because of their cost and other concerns of inducing certain arrhythmias. But for trials and theoretical aspects, they are very, very important. Gastroesophageal reflux disease must be ruled out. So I think it's, as of now, we have sophisticated tests, but I think clinical judgment in addition to assessment for other aspects like anemia, thyroid disorders becomes very, very important.
I think your mention of anemia is so important because so many times you've seen patients with positive stress test. The first thing you should do is look at the hemoglobin because clearly sometimes the hemoglobin is low and you say, oh, it's all, don't worry, just correct your hemoglobin, then everything disappears. So I think very important point is mentioned. You mentioned look always for anemia in patients with positive stress test, especially when other things don't fit.
Yeah, I just thought you covered everything so well. How did it slip your mind? But it happens with experts like you. And in fact, I was seeing one patient today in my clinic, and he's a heart failure patient as post CABG, has some CT angiodistal disease and angina, and his hemoglobin is 9. So, and ferritin is 18, the phosphorus saturation is 5. So I think IV iron therapy will benefit him, and it was just fresh in my mind, so I mentioned that, sir. Thank you.
Thank you so much, sir. So next question is from Dr. Vivek, who asks, in which subset of CCS patient Nicorandil is most beneficial? Dr. Cooper, sir, would you like to take it first?
Yeah, so as we have already discussed that there is actually no first-line therapy as far as trial evidence is concerned. Conventionally, nitrates have a first-comer advantage, and they have been used most commonly. Some limitation of using nitrates is hemodynamics and headache and certain side effects. Beta blockers have a mortality benefit, especially in documented coronary artery disease. But many times these patients, as Dr. Dalal was also discussing, that you do angioplasty, still the patient complains of angina. So there is no clear choice of one drug over the other. But yes, if you have contraindication for beta blockers or the heart rate is on the lower side, maybe you use Nicorandil as a first-line drug or metabolic modulators as a first-line drug. Sometimes you may have angina in patients, the heart rate is around 50. And the patient is not on beta blocker, doesn't have a thyroid problem. So obviously you don't want to use beta blockers. You don't want to, and a patient may have a blood pressure borderline around 90-95, and you find these kind of patients off and on. So you not like to use calcium channel blockers. So here in first choice comes a drug like Nicorandil or trimetazidine or ranolazine. So, I mean, it depends upon the clinical scenario, and the octet of drugs and the combination of various drugs has been beautifully shown in one of the slides by Dr. Dalal sir. So I believe that working these patients and individualizing drugs according to the clinical scenario is important. Somebody who has a tachycardia, hypertension, beta blockers, first choice. Beta blocker contraindication because of asthma, calcium channel blockers. You have borderline hemodynamics. You don't have much of tachycardia. drugs like nicorandil, drugs like trimetazidine. If you're an elderly patient prone to Parkinson's and neurological disorders, you don't want to use trimetazidine. You want some diabetic improvement, HbA1c improvement, maybe ranolazine. So I think all these things, and sometimes the patients may require a combination of all these drugs. And we must know that certain combinations are to be avoided, like ivabradine and calcium channel blockers, and so on and so forth. But many times we may need to use multiple of these drugs to actually give them benefit.
I think the last slide which I showed, which was a beautiful slide from ESC about how you look at various parameters and then decide, depending on, as you mentioned, the heart rate, blood pressure, heart failure, etc. I think clearly one thing should remember is that when a patient complains of angina, you've not done an angio, so you don't know whether it's normal arteries or otherwise. Don't keep adding one group of drugs again and again. So don't add beta blockers, calcium channel nitrates, same thing again and again till the patient actually stops taking the drug because too many side effects are coming. Try and combine the drugs. So if you're using a beta blocker, patient's not feeling better, then use trimetazidine, use ranolazine, use nicorandil, and try and balance the metabolic drugs with the hemodynamic drugs, balance the microvascular beneficial drug like nicorandil with the other drugs. We know that nitrate, you get nitrate tolerance if you keep giving the drugs too much. And of course, many patients get headache and don't take nitrates. So I personally use nitrates more for acute episodes and use other drugs which are much more tolerated by the patient along with beta blockers for management. So I think we have a wide variety of choices of patient. I think that as I mentioned, and of course all studies show, we don't optimize our medical treatment before we do lots of other things.
Very, very important point of optimizing the medications. And I think not only in CCS, but in heart failure, dyslipidemia, we have so many choices now. And I think with a good medical therapy, diet, lifestyle modification, many of the procedures can be avoided or at least delayed.
If you look at it, we know from all these studies that procedures like PCI, etc., don't really change prognosis, don't actually prevent future infarcts or future cardiovascular events also. But what really does prevent future cardiovascular events is reducing your lipids. For example, when we have all these trials, especially with the PCSK9 inhibitors, reducing your LDL levels to very low levels, below 35 as LAI is guided, you are also part of it. So as mentioned, reducing LDL levels to below 35 is very beneficial. There are at least 3 major trials which have looked at intracoronary IVUS or intracoronary OCT to look at these plaques. And when you reduce your LDLs to these levels, let's say below 30, around that area, not 50, 60, doesn't make that much problem, but at levels below 35, you actually get the whole lipid arc reducing. You get the lipids becoming more fibrotic and calcified, so they're less likely to rupture. Therefore, they make it less vulnerable to myocardial infarction. The fibrous cap on top of the plaque becomes very thick and less likely to rupture. So we have got clinical benefits, which we see with all these trials in terms of less cardiovascular events and much more improvement in terms of future events, both stroke and cardiovascular and peripheral artery disease. Even remember, with lipid lowering, amputations also become less. So it's not just heart attacks and stroke, even amputations become less. So I think concentrate a lot on lipids, which I think we are not doing, because I think that's a great beneficial effect. So when you can actually reduce or prevent plaques from rupturing and therefore not producing myocardial infarction, and then treating with control of angina, then I mean the procedural interventional need will become less and less if you are aggressive in looking at these parameters.
Absolutely, absolutely.
Thank you so much for that detailed discussion. I think we have covered almost all the questions. So we'll take one last question. This question is from Dr. Akhil, who asks, Sir, coronary magnetic resonance angiography. About coronary magnetic resonance angiography, who are the right patients for this investigation? Dr. Dalal, sir, if you would take it first.
You're talking of cardiac MRI, is that what you're talking about? Because coronary MRI is not something which is yet established. Yes, CT angiography has been now greatly improving. There are great new CT machines where you don't need to do all those things we used to do in the past, like get heart rate down, etc. There's a new CT machine which comes, which is now causes subtraction of the calcium, so that the big problem of CT angiography is calcification. If you got too much calcification, the CT angiography is somewhat limited in its assessment. But the more recent CT machines which are coming out can subtract the calcium and give you much better information. It can also help you when you have stents. Sometimes when you have stents, especially multiple stents, the CT angiography may be difficult to evaluate because you can't see so clearly through the stent, and if there's an in-stent restenosis, etc., it may be missed. So clearly, CT angiography is developing more and more, and I think CT angiography is eventually, in my opinion, going to become a pretty gold standard of future management of coronary artery disease. So far, it is not. I do not see any surgeons taking up a patient for surgery on the basis of a CT angio. So I think at the moment, regular coronary angiography is important. MRA is important more for the myocardium and rather than for the coronary arteries. It's very, very useful in patients with various form of cardiomyopathies in terms of both in acute myocarditis, chronic cardiomyopathies, evaluation of HOCM to see the degree of fibrosis. So MRA has its own usefulness, but I don't think that it is at the moment sufficiently developed to look at the coronary arteries, unless something has come in the last 24 hours.
Thank you, sir. Dr. Kubasov, anything from your end? Would you
Yeah,
like to?
Yeah, I think absolutely I concur with everything. And sometimes cardiac MR can be used to guide electrophysiological procedures, ablation by looking at scars and other aspects. And cardiac tumors at times, you can be more sure about what kind of tumor it is. But again, cardiac MR is something which is not routinely available everywhere. And sarcoid is one of the disease and cardiomyopathy. So technical challenges are there, and also reporting challenges are there. So more of an investigational tool, and only in certain diseases it may help. MR angio of the coronary arteries is not much of as of now importance. And one of the slides I showed the microvasculature, which was assessed by cardiac MR in nicorandil and non-nicorandil groups. So that is again something which can be used in a research or a thesis setting or the study setting. So these are some of the roles of cardiac MRI, and mostly it is a coronary CT angiogram, which is, and the calcium score, which is more important to assess coronary artery disease. Yeah.
Thank you, sir. For the final vote of thanks, I now invite Dr. Parthasarathy, sir.
So, thank you so much, Dr. Charvi. Thank you so much, Professor Dalal and Professor Cooper. It was truly an amazing oration from both ends, focusing on optimization of angina management in CCS patients, covering the length and breadth of the topic. We are very sure that the audience who has been part of the program has had their learnings and takeaways, and ultimately it'll empower them in their clinical practice. We've had more than 2,000 logins, just to say, at this point of time in the late evening post 9, especially with Maharashtra even having its festive season on. So thank you so much, Professor Dalal and Professor Cooper. Dear audience, we thank you too for actually taking your valuable time and being part of the session, and empowering yourself to improve your patient care and your patient outcomes. Last but not the least, we also thank DocMode for aiding in the very smooth streaming of this webinar. So thank you one and all. Good day and good night.
Thank you. Thank you.
Thank you, Kuba sir.
Sirs.
Dalal sir, thank you so much. An honor to host you, as always.
Thank you so much. Bye.